Okay, we are ready to go.
All right. Welcome to the April 9th, 2026 meeting of the Health and Education Committee. My name is Rebecca Cott and I'm the chair of the committee. Tonight, we are joined by Assistant District Manager Brendan Berth. This meeting is called to order at 6:31 p.m. As a reminder, New York State law requires all committee members who are not able to attend the meeting in person to have their cameras on and their first and last names displayed from the time the meeting is called to order until the time the meeting is adjourned. Members of the public who are attending virtually, you can raise any questions or comments that you have through Q&A feature of Zoom. Members of the public who are here in person, there is nobody, so I'm gonna skip that section. We need a volunteer to take minutes. If you're able to, please let us know. Anybody? So, let's see. Is Liz Barr still on the committee?
Yes, she is.
Is she gonna be here in virtually or no? Because I haven't heard anything.
No, she is not.
So she's gonna have to watch the minutes anyway.
Yeah.
So I'm going to say Liz Barr.
Okay.
I'm volunteering Liz Barr.
Voluntold.
Voluntold Liz Barr. All right. Thank you in advance, Liz Barr. We will now take attendance by roll call. Brendan will conduct the roll call.
Okay. Committee members, I will call your name. When your name is called, please say present. I will announce if there is quorum. Qualified. I do not see here. Marty Barrett might be with us. Elby Barosa.
Present.
Liz Burr isn't here. Stu Desser. You are. Rock Friedman.
Present.
Gloria Haig.
Present.
Rabia Iqbal, I do not see. Rupal Kakad,
Present.
Kate Kennedy,
Present.
Katie Landa,
Present.
Kevin O'Keefe isn't here tonight. Rubin Siddiqui
Present.
and Kat Valero.
Present.
We have a quorum.
All right. The agenda for tonight's meeting was distributed ahead of time by the board office and reflected on the screen before you. If there is no objection, we will adopt the agenda. Members of the committee, if you object to adopting the agenda, please raise your hand. Seeing no objections, the agenda for tonight's meeting is adopted. The minutes from the March 12th meeting were distributed ahead of time by the board office. If there is no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, please raise your hand. Seeing no objections, the minutes from the March 12th meeting are adopted. They will soon be available on the CB6 website. Some ground rules. In order to conduct an efficient meeting, let's observe a few ground rules. No one may speak until granted the floor. Committee members who are here in person, if you have a question about committee business or wish to make a motion, please raise your hand and I will identify you so you can speak. Committee members unable to attend in person, if you have a question about committee business, you may raise your hand through Zoom and I will identify you so you can speak. All committee members, it is extremely important that only one person speak at a time so that members of the public watching at home can understand what is being said by each committee member. The chat function for the committee members present via Zoom should not be used for committee business or questions about agenda topics. All such remarks should be made on the record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or to state in writing information like an email address that was already stated out loud on the record during the meeting. So the first item on tonight's agenda is a presentation by Dr. John Genova, Clinical Assistant Professor, Department of Emergency Medicine at NYU Grossman School of Medicine on bicycle safety and how best to protect as a cyclist. So I'll hand it over to you, Dr. Genova.
Thank you so much for that. And I'm really thrilled to be joining all of you tonight as well to go through this talk with you. I know it's very topical as well for me as an ER physician, and I'm sure, we've seen crazy cyclists as well and crazy injuries, and we've probably also been personally involved in some of these injuries too. So I definitely think that this is a very, very good topic to go through. So I will share my screen. All right. Is everyone able to see my screen okay?
Yep.
Yes.
All right, great. So again, as was already said too, I'm here to discuss just bike safety and as it relates to me as an ER physician and just ways that we can kind of see what injuries happen from them, how best to avoid these injuries, and how to manage going forward as well. So just to give you background in terms of what we're going to be discussing today, we're going to talk about the cycling crisis and by the trends and numbers in terms of injuries, the type of injuries that we see, head and brain injury specifically, because this is the number one killer and the biggest risk when bicycling. Other injuries as well, including fractures, road rash, any other internal injuries, and the biggest risk factors that make it happen, and then simple steps that can actually work. And then afterwards, if there's any other questions, I'll be happy to answer anything. So just looking through some of these numbers as well here, we could see that about 30 cyclists in 2023, that was the highest in the decade. That was the amount of deaths happening in that decade as well, or sorry, within 2023, just the year alone. So that was a very high number of deaths that we witnessed for that decade, and it was a high then. We see about over 5,000 injuries in 2023 as well. The ER visits, it is very daunting as well, too. About 120,000 visits within that year. And I can say on any given day in an ER, I will see about 4 to 5 at a minimum. You know, it can be up to about 20 to 25 people as well that come in with bike accidents. So this happens very often. Hold on one second. Okay. And to just talk about the difference really between e-bikes versus pedal bikes. So e-bikes obviously are much faster, as we've probably seen walking through and seeing some of the delivery services as well. Speed almost at rates that are similar to moving vehicles and motor vehicles that are there as well. They can lead to much more serious injuries just due to the sheer velocity. Also, it really does, you know, you're really more likely to experience a more, I guess, harmful injury as well, mainly to the head and neck area, also the head and face area as well too on an e-bike than you are with a pedal bike. Internal injuries are also much more likely on an e-bike just due to that sheer impact as well, if you do get into an injury there. The rate of e-bike related injuries from 2019 to 2022 starkly increased by 293%. So I think with more people using these e-bikes as well, this is even a better topic to kind of go through just to be sure if you're not even riding an e-bike and you're on a pedal bike, you're in the same lane as a lot of these e-bikes as well too. So it's going to be a good way that you can try to keep that, you know, in your frame of mind, and also to kind of help make sure that you're avoiding them as well, because any crash from an e-bike as well into a regular bike will cause serious injury with the way that they're moving. There was a study done from Hunter College as well on this micromobility. They found that delivery workers actually are much safer and more law-abiding than these non-commercial micro-mobility riders as well. So these are just pedestrians that have e-bikes, you know, that are just using it for fun or just own one and then riding around. We see much more injuries from those individuals than we do from the food delivery workers, although we still see a decent amount from the food delivery workers as well. All right. So the type of injuries that walk in or wheel into RED are mainly head and brain injuries. So again, these are mainly concussions for the most part, but this covers an entire spectrum in terms of just head injuries. So this can also include intracranial hemorrhages. So that just means blood around the brain. So anytime you kind of have that impact and injury causing that shearing force as well, that can kind of rip some of the vessels in the brain and causing some blood to actually pool inside, which will increase pressure. And that's the number one killer as well. We do see a lot of fractures, mainly in the upper extremities. And the reason I say that is because the first thing you do when you fall off a bike as well is you want to put your arms out. You want to put your arms out to try to brace the impact. So we do see a lot of upper extremity fractures. We see a decent amount of road rash and lacerations as well. And then also leg fractures. So if e-bikes are a lot heavier too. So we've seen too when they spill over, even if you're not going at a fast clip, it can roll over onto your hip, onto your leg, onto your knee, ankle, anything, and it can just snap it in half. Facial injuries are very common as well. Internal injuries, not as common, but we can see it too, mainly on e-bikes, just with the, I mean, and also depending on the collision as well. Spinal injuries also have happened as well. The biggest thing too, what scares us the most really is when people say that they're not wearing a helmet after an injury like this too. So someone can really look fine on the outside. They could not even have any signs of bruising or anything, just some pain. But if they're not wearing a helmet and they just look unwell, then a lot more can be uncovered, you know, by coming to the ER. So as I've said already, the number one killer here is head and brain injuries. So about 60% of cyclist deaths normally involve these brain injuries. 47% of all bike crashes as well result in some type of head injury. Helmets are the number one godsend that I can just like, if you're riding a bike, just please wear a helmet, because the CDC, and there's been a lot of other numbers that we can pull up here too that showed the reduction of harm as well by 60%, which is very, very large at that point. So I think it's safest if you're going to get on a bike at all, just always be cognizant to make sure that you're wearing a helmet. And here we go again too, just to give some more numbers as well. As I was saying too, did they wear a helmet? So 62% of these fatalities involved with these individuals were people that did not wear a helmet. And again, this is a law required by New York State as well. So again, just being a law-abiding citizen, in addition to just making sure that you're taking care of yourself when you're riding a bike and going out. So even if you forget it at home, I would almost, want to, tell you all just to not even go out and ride a bike if you don't have a helmet. It's just not worth it at that point. And to go through again some of the other injuries that we've already talked about. So the wrist collarbones, those are the ones that we see the most. And again, that Fuchs injury, the fall on outstretched hand, that is the main thing outside of head injuries that we see as well. So that's because it's just the natural reflex to put your arms out. So we don't need to go back over this, but again, these are the main injuries that we see outside of just brain injuries, but brain injuries obviously being the most dangerous going forward. All right. So when and where the crashes happen. So 89% of these cycling injuries do occur at intersections, believe it or not. No shock that it happens during peak hours for commuting because it's a lot more crowded there, not much more wriggle room. Also, many more cars are out on the road as well. So anywhere from 7 to 9 a.m. and then 4 to 7 p.m. And then weekends, midday rides. Again, it's just when peak volume with like individuals and community members being outside. Top causes here are failure to yield, red light running, dooring, distracted driving. I would say distracted driving and distracted bicycling also because you will see some people on bikes as well, hands off, looking at their phone, just like drivers when they're looking at their phone as well. Be on the lookout. Try to stay as far as you possibly can away from those individuals. And I know it's tough to see people in a car that are distracted, but again, just make sure that you're cognizant of where you are in relation to these vehicles and these individuals as well. Blind spots, trucks and buses. So leading cause of fatal cyclist crashes in New York is from trucks and buses, and that's because there are many blind spots on the buses side, so they can't really see you. So anytime individuals are traveling close by one of those trucks or buses, just be cognizant of that and try to stay as far away as you possibly can, because believe it or not, they're probably not on the lookout for you, and even if they were, they probably couldn't see you just with the amount of blind spots that they have. Again, large vehicles, this is, like I said, the deadliest, threat here. So I can kind of show you here in this little pictograph as well, just how big and massive those blind spots are. So directly behind them, and then also you can see even too, if you try to trail backwards a little bit from the truck, there still has a pretty large blind spot there. So I would almost just say avoid at all costs, just being anywhere near within 20 feet of these larger vehicles just to be safe. And you make sure to, be seen, be sure that, you're seen when you're stopped, and then also just be aware of everything around you. And with these injuries also, this is where we see the most intra-abdominal injuries. So those type of injuries outside of fractures alone too are very high impact injuries, and they may not show up right away. So any sort of like belly pain, anything of that nature, you can also see, some bruising on the inside of your belly. But even if you have like rib fractures, anything like that too, there's a lot of vessels in those areas too, and they can start bleeding, and then there's no way for the blood to actually get out. Even further in, it can injure organs, and it can cause leaks in the organs as well. So blood in the belly is a bad thing. It's usually always surgical. There's really, it's a very tough journey. So this is something that you really want to be aware of, because we've seen traumatic amputations, we've seen this massive internal bleeding, we've seen fatal multi-system trauma, meaning affecting more than one organ system, and we've seen where individuals have actually been run over by these large vehicles as well, so where they go directly under it. So if you can't see the driver's mirror, they're not going to see you. So keep that in mind. All right, so road rash and laceration. So it sounds like it's not a big deal, but everyone knows how dirty the streets are at times too. So anytime you get a nick, a cut, anything like that, debris is going to get inside, and it's going to start coagulating with a lot of your soft tissue. It's also going to be there with your blood as well too. So these deep abrasions that go down inside the skin into the fascia, avulsion injuries, just meaning some skin flaps and tears like that, complex lacerations. A lot of these may end up requiring some plastic surgery just because they're very complex injuries. It's not just like a simple knife cut or anything that's very linear that could be easily repaired, and also does have a decent amount of debris. So the washout that you'll need to do is pretty extensive. Also, there's so many nerve endings all around these bones as well too, so they can cause severe nerve damage. Biggest thing too is infection risk. So obviously making sure that, getting a Tdap afterwards as well if it's not been up to date, but MRSA as well is a major, major, major risk of infection too when you have these road rash injuries. And the long-term impact again too. We've seen people that have needed skin grafts, they've had permanent sensory loss or nerve damage in their hands or legs, and it gets overlooked often when you're in the ED. So when you think about this too, this is something I keep in mind constantly. Road rashes, they may seem benign, they may seem just like a little scrape, but it can usually cause a lot more damage to you. And to prevent this, I always tell people as well just to kind of have padded gloves to protect the palms because I always think too, it's just the natural reaction. That's the first thing that goes if it's not your head. Your hands are going to be out there too. So try to wear padded gloves directly on the palm areas right here. That'll help protect you as much as it possibly can. And long sleeves are always great too. Cycling pants, again, reduce severity significantly and kind of help out with all of this. Okay. And again, how to protect yourself. So make sure you're always wearing a helmet. Make sure you're always avoiding those large vehicle blind spots. Signal the turns as well. So use hand signals, be predictable. Make sure that you're making yourself aware, and make sure that people also are aware of where you are in relation to them as well. Check behind you frequently before you change lanes. Just making sure you have a good overall wherewithal. And then also just making sure, obvious, but stopping at red lights and signs. A lot of times, people wear a bike just to get places faster, which is fair, but at the same time, you must still follow all the bike safety laws that are in regulation, and that includes stopping at all red lights and signals, because otherwise people are not going to see you. You may forget for one split second, lose focus, and that could cause one of these injuries that we talked about, which we want to avoid at all costs. Use lights at night, wear reflecting, material at night too that people can see. Just make yourself try to wear as like fancy colors as you possibly can at times too. If you think that you're going to have any issue, try not to wear all black when you're riding at night as well. Lights may be difficult to come by, but if you do have any reflective material or clothing, that would be a benefit for sure. And make sure headphones, and see a lot of people that ride headphones and a lot of people that come into our ER as well are people that wear headphones while they're riding a bike. Again, it's just another distractor, but more than anything, it's because they're not able to pick up on the subtleties of, car horns as much, or even just like skidding or any just sort of vehicle noises or anything around them. You're just less aware of what's going on around you, and that can lead to, bigger issues going forward. Again, helmet, biggest thing. It can reduce head injury to 48%, traumatic brain injury even further, facial injuries, and fatal injuries, 34%. Now that's massive. So always be sure to wear a helmet. Now, pediatric non-helmeted bikers as well, they have a higher risk of serious head injury. So this can reduce it even further by up to 83%, just because children usually have larger heads in proportion to their bodies until they grow into their full bodies. So usually that will be the first thing to strike too. So always make sure they're wearing a helmet as well. And now just to kind of go over some of the bike laws as well. Again, we kind of went over some of this too, so don't want to belabor this as well, but just make sure that you're kind of keeping this in mind when you're riding a bike or the next time you hope to get out and ride the bike. And again, we've seen this as well, some of the safety tips going forward, and slow your roll. So make sure that you're looking out for people, that may be vision impaired as well. So you'll see the long white sticks and red canes. They'll have dogs with guides. Always make sure that you wait and let people go first. Keep the crosswalk as clear as possible. Pedestrians will always have the right of way on shared paths. So try not to ride up also behind anyone or around any guide dog or owner, and slow down near people when walking. Make sure that you do have a bell. A lot of bikes don't have bells, but I encourage it just to make yourself known as well. Ring your bell, call them, let you know that you're coming close. All right, more safety tips as well. Be visible, biggest thing I can say, but also be predictable. So make sure you know the signals to use when you're moving left and right. You're using them appropriately. Drivers can also see it and pick up on it as well too. Make sure that you're following the flow of traffic and all traffic laws. So again, stopping at all red lights, making sure that it's clear to go before you can, and just following everything as if you're riding a bike. I just kind of think of it to make sure you kind of follow all the rules as if you're riding in a car. All right, now I did want to talk about this as well, just special risks with riding with children. So children under the age of one, cannot be carried on a bicycle. Small children must be carried in the affixed like child carrier that are available out there. children fall differently as well. They don't have the same awareness of danger that we have, slower reaction time. They're smaller in stature. They're more prone to injuries, but more specifically to the head and face because of that head to body ratio. When you're younger, you have a lot larger of a head, so it's a bigger target to hit. Under 13, make sure to go to the sidewalk. So the law is that children under 13 may ride on the sidewalk. They can't ride on the street. So adults should ride alongside kids at 13 years or old, younger as well, like on the street with them. So just make sure you're around them, make sure that you're aware, and make sure that they're not in the actual road. Now, in side-by-side intersections, cross with your child at every intersection, make them visible to drivers. Same thing just for yourself as well. And helmets, again, being non-negotiable. So also in terms of when to go to the ED. So this is something I usually discuss with most people as well too, about after these bike crashes happen. So even if you feel fine, it may not be fine. So I would say that these are the biggest things that if you have any of these going on, I would just go right in and see a doctor. But I also tell patients a lot of times too, if you're in doubt or if you feel like you may need to go see someone, you should just go. Usually your gut feeling is the right feeling, and usually you can find a lot more that way. But anything like a loss of consciousness, even if it happened for a second, even if you don't remember that you passed out, anything like that, I would still come in. Obviously, confusion, memory gaps, that's a little bit more concerning for a concussion or even a bleed in the brain, headaches that get worse over time, any vomiting or nausea after the incident as well, because these can all be signs and symptoms of these traumatic brain injuries. Visible deformity of limbs, that goes without saying. If you see a bone popping out or anything else, I'm sure you're going to go right into the ER, call 911. Inability to bear weight on any of your joints. So if you fall down and try to get up afterwards and you're having trouble, come right in. Any wounds, it says deep wounds here, but I would still say like any other softer wounds, I would still go in and get checked because again, it's that infection risk I get worried about if it's not a super deep wound, but you also don't want to wait over time and then start developing some of that nerve damage because once it hits that level, it may be irreversible. So better to go in earlier and be safe. Outside of that, chest pain, difficulty breathing. So a big thing that we see as well are rib fractures. So pneumothorax is essentially when your lung is dropped. So that just means it gets compressed because there's too much air popping in. So your lung completely deflates. And that can happen due to those rib injuries because they're very sharp once they get broken. And they can actually puncture the pleura surrounding the lung, which kind of keeps it inflated. So when that happens, obviously this is a big risk. So any sort of chest pain or anything on your body, like up in here in your thorax area, just make sure you come right in. Abdominal pain after the impact as well. Any sort of abdominal pain, doesn't matter what, not even seeing any rashes or any marks on your belly or anything of that nature, come right in. If it hurts at all, there could be a chance that you may have some internal injuries and we need to do some more work to figure that out on our end. So CT scan takes minutes, but when you're in doubt, go in, it could save your life. All right, and some of the take-home messages again too. Don't want to belabor the point as well, and want to be cognizant of everyone's time, but just make sure you wear a helmet every time. Just the safest thing, and it's really, really not worth all these injuries that we've seen. Stop at all red lights. Follow all traffic laws as if you're riding a motor vehicle as well. Avoid blind spots of trucks, buses. I would just say avoid them at all costs. Try to stay as far away from them or far to the side of them as you possibly can. Use lights at night. Put down the phone while riding and make sure you go to the ED if you hit your head at all. And I caution you to say, I've seen people too that even look great after hitting their head, very minor injuries, and they develop a brain bleed. So these are things to definitely keep an eye out. And that is all I have on my end. So if anyone has any questions, I'd be happy to answer them.
Go with Mubin.
Hi, Doctor. First, thank you so much for the work you do. We realize more than ever now how crucial it is. So thank you so much. I have a quick question. Your presentation was from the perspective of bicyclists. So when you were giving the data on accidents, was that only accidents incurred by bicyclists or people that they harm as a result, like they run into and the other person gets injured? Are those captured in your numbers?
That's a good question. So this was specifically bicyclists, but I will say that we do see a decent amount of pedestrians, not as much injured in those accidents. But again, they're the same type of injuries that you would expect, even if you were hit by or if you were on a bicycle and had the same injury. So these also go into the same buckets as they would for anybody that's a pedestrian that gets hit by that. I consider it as well e-bikes. If a pedestrian's hit by an e-bike, I almost consider it to be the same thing as as a pedestrian being hit by a motor vehicle. So So still this data and a lot of this data too was from the help of the trauma team over at Bellevue. We work very closely with them. So they've given us a lot of the data that they've been working on their end to try to help prevent some of these injuries. But yes, from this standpoint, and to answer your question, it's mainly from bicyclists. But I would say if this happens too, in terms of just pedestrian injuries, same thing goes, same rules go.
Thank you.
And then,
Thank you for the presentation, Dr. Genova. We had a presentation not too long ago about the severity of strokes and the timing being a critical element, and knowing that you work in the ER and see this pretty often. What is the time limitation upon the incident and coming into a facility? What is you mentioned certain traumas to the brain and different injuries, and I'm just curious, is there a critical juncture that somebody should come in and be seen?
Yes, so it's not the same in terms of some of the ischemic strokes, because those timeframes are more in terms of medications that can be delivered safely within a specific time frame to prevent that. When these injuries happen, mainly the brain bleeds, I'll speak on too. You do want to get in. I mean, for all these injuries, you want to get in as fast as you possibly can. But again, outside of that, in terms of the injuries to the brain itself, there generally isn't a 6 hour to 24-hour window, but some of the mortality benefits that we've seen is that if you wait longer than about a 12 to 24-hour period, your mortality rate can increase drastically. So I would say within that first 12 hours after an incident, even if you could just if you feel okay otherwise, but you did hit your head and you just kind of were wondering whether or not you should go in, I would go in if you're still within that 12-hour window, because sometimes what can be done is if they notice that you do have blood in the brain, they can try to, if they have a pocket to actually go in and get it, they can actually suck out some of that blood surgically, which is good. But there are times if it's there for too long, if it gets a little bit older and it starts getting layered, they can't do that and they can't go in and do that. And sometimes it will go away on its own without any intervention anyway, so it'll dissipate. But the biggest issue is that if you sit on this for too long and you start developing symptoms that are worsening, that can be almost irreversible. So, and generally they can happen anywhere from the moment of impact, depending on how severe it is, all the way up into that 24-hour standpoint and further. But I've seen people that have fallen, hitting their head, even just from bike accidents, that have come in 2 days later and they haven't had symptoms and they started developing them right there. And they were able to turn around and have good outcomes, but there are people that don't have good outcomes with this as well. So I would say generally within a 12 to 24-hour time frame, you can reduce your risk of mortality largely if you come in at that point. Because the important thing is basically just that if you develop those symptoms, and we've seen how debilitating, maybe some of us have seen how debilitating strokes can be. So when you start developing those symptoms of a stroke, because it should be considered the same, from a hemorrhage in the brain versus just an ischemic stroke, which is loss of blood flow, it should be thought of the same. You can have the same symptoms and you can lose function in an entire part of your body. And when that happens, it's a lot harder to regain that function afterwards.
Thank you so much.
Hey, Dr. Genova, first of all, thank you for coming to speak. Really appreciate it. I work in radiology and quality at Mount Sinai, and we focus on medical errors. And when there's a medical error, there's an individual error and a system error. And we tend to try to focus on the system errors because those are the things that can make more of a difference. And when we focus on the individual errors, they tend to recur a lot and they're really hard to fix. And you can kind of think of that with gun violence too. In the US, we just say, okay, just try to be careful with your gun. Whereas in Europe, they ban guns. And so in the US, we say, just wear a helmet. When you get to the traffic intersection, be careful. But we don't look at the system factors the vehicles are getting much bigger. The heights in the front are getting much better. So people can't see children underneath. Our roads are designed for speed and not safety. Our traffic laws are very lax, they're not enforced. Whereas in Europe, like in Amsterdam, literally nobody wears a helmet, all of the Netherlands, and it's orders of magnitude safer. So this is feedback as a fellow physician, because your presentation was great. Just like in medical errors, we focus on system factors. In traffic deaths, we can focus on system factors too. And that's going to have a much higher impact because in the US, traffic deaths are skyrocketing compared to peer nations. We're doing a terrible job with traffic deaths. So I'll stop there. But I encourage you when we have meetings about bike lanes and safe for you to come.
Absolutely.
And with your experience, and people will trust what you have to say because you're a physician, you see it. And if you advocate for these safe infrastructure, it'll make a difference. So sorry for the sermon, but feel free to respond.
Oh, absolutely. I trust me, I couldn't agree more. And I'd be thrilled to be invited on to some of those talks as well and to listen in and, shed some advice because I work in quality and safety as well at NYU. So I see a lot of this. And, to your point, we discuss a lot about, the human sharp end error versus the system factors. And that's why the context is so important here. We're in largely in an area too where these bike laws, you're right, are essentially just like changing, but it's also for the worse. I think, really, really encouraging those high speeds, encouraging larger vehicles just to be, be on the roads more often, and just the congestion alone. I think that, just the context there, you're right. I think so making us safe in this realm, it's super important, but you're right. I think the reason that we need to be a little bit more cautious here is because of how our bike laws are set up. So you're right. And I think the only way that we can really attack the system, in terms of changing is just through policy. So I would be thrilled and more than happy to.
Go ahead, and then Katie.
Hi, just quickly, I would probably after this, if there's a way, if you know of any resources where it explains how to ensure a proper fit with a helmet, recommended types of helmets. I mean, there are like hundreds of types of helmets. That would be really helpful.
Absolutely. Yeah, I can try to send some of those that I have some infographics and information on bike helmets that I can send over afterwards, but definitely.
Thank you.
Katie?
What should one do if they witness a bicycle accident? What's the best thing to do?
If you witness a bicycle accident, I would call 911 to get an EMS truck out there just to evaluate them. I think, again, these bike accidents, they may look on the surface to be, nothing, but I've seen a lot of times too where they've turned into something big from that. So I think the best thing to do as a bystander, if you see that happen, to just call 911, call an EMS truck, get them there and have them, evaluated medically. Obviously, you can't force people to stay by for medical evaluation, but you're doing your due diligence, as a good bystander and a good citizen. So that would be my advice there.
Thank you.
I wasn't clear where you get all of your data from, but I believe you mentioned that 89% of mishaps occur in intersections. Is that right?
Yes, and this was all largely from the CDC mostly. Yeah.
So, do you know if these intersections are those where there are bike lanes, or are these unprotected intersections?
That's a good question. But we've seen actually too that they did take into account bike lanes as well. They didn't kind of risk stratify them in terms of both, but it happened on both ends. So there was still that similar amount of percentage, I think, also happening at ones that were with bike lanes. But again, I think a large element of that is because certain individuals maybe not following those bike safety laws or just the road laws. So it could be people even on the bike lane, just running through a red light, things like that.
So also you said that the injury rate for bicyclists on electric on e-bikes rose something like 300%.
Yep.
I'm not sure what is when you say rate, do you mean per certain number of riders or just the numerical incidence?
Just the numerical incidents. Yeah, largely. Yeah. And again, that could too just be because the rise of e-bike popularity and the amount of e-bikers that are on the roads. But I will caution to say as well, like I considered those to be motor vehicles with how heavy they are, how fast they can go, so they can cause so much more damage.
So I just want to make one more point that, in the individual factors you're listing, probably one of the most, maybe the most important individual factor is the route you choose. Like in a lot of the roads in the US, you're just going to die if you try to bike on these roads. And so choose it, when you bike in the Netherlands, you don't really think about the route you're going in because all the roads are safe. Many of the roads are just death traps in the US. So I don't know, maybe I would just include that in your slide that our roads, a lot of them are death traps.
And not just Europe. I have been to Ecuador, Galapagos, Brazil, Chile, like a lot of South American countries. Even they're so much safer to bike on than American roads. Like I actually have taken pictures on many different vacations. And I'm like, oh my God, this is so much, like, just looking at it, you don't even need to think about it more than to, like, you just look at it and you're like, oh my God, this is so much safer for a bike lane than what we have.
I think we're just such a car culture.
Yeah.
Such a car culture, and the bigger the better, right? You know, it's cultural.
So I have a question. So I know some of the data you presented was from 2023.
Mhm.
Has congestion pricing had any effect on all of this with less cars coming in, or has that not really changed
It
anything?
hasn't, it hasn't changed as much. Yeah, it really hasn't, it really hasn't reduced it as much as I would have maybe thought. But again, you know, it was interesting to kind of see, and that's a great question. I was thinking the same thing when I was going through some of the numbers. I know they're still running. I know the Bellevue Trauma Team as well is still running a lot more numbers to kind of be more up to date in terms of 2026. They haven't kind of come out with their full report yet, but yeah, no, I think it's definitely, you know, it's a major issue, but mhm.
And I don't know if you can do this or not, so I'm just gonna ask. You also mentioned the new study from Hunter College.
Mhm.
Would you be able to send over that study?
Yes,
Or you don't
I
have
can,
access?
yeah, I can, yeah, no, I can definitely get the information and send it over, but they did a lot of work on micromobility. And it was kind of also just looking to make, because we do see a lot of the delivery workers, and other individuals that are employed as well that ride those e-bikes, you know, just to drop off deliveries, and even Amazon, those little carts that kind of ride around too. But we did, like, I would have thought, you know, that by adding more of them on the road, they would also be the ones that are more likely to kind of come into the ER as opposed to just pedestrians. But not the case, which is which turned out to be. So I was shocked by that myself, but I will send over the literature that I do have from them that they can give me.
Excellent. And Mobeen has her hand raised.
Yeah, I really just had a comment that I presume you already do this, doctor, but it'd be wonderful if, you know, some of these presentations can be made to enforcement agencies, be it the NYPD or whoever, because one of the things, one aspect of bike culture that we are experiencing, while it's amazing that we can be more environment friendly and be on bikes more than cars, but in my neighborhood, at least in my absolute immediate neighborhood, the bikers are all over the sidewalk, and I'm surrounded by NYU and other hospitals, and you've got the seniors walking around, the aged walking around. The bikers are going in every direction on the sidewalks, let alone the bicycle tracks and all of that. So I feel like maybe some of this data on accidents, et cetera, is so crucial and critical to share with enforcement agencies so that they understand. I think bikes look very benign to many people, including law enforcement agencies. So when they see someone biking the wrong way, unless they're a famous celebrity, they don't even stop them.
Mhm.
And I've done that many a times to people saying, please, sir, this is, you're going the wrong way. They don't care. So I just feel that there has to be some tie-in with agencies like yours, the hospitals and people who understand the impact of this to be shared, because, you know, sadly in accidents, the fault comes from many directions. And I think that's something we do need to address.
No, great point. I think every day I go to work as well, I see so many people on the sidewalks, and I say the same thing. I try to comment to them, say, please, you know, get off the sidewalk, this, that, and the other. But you're right, no one seems to care. But it's a major issue. And even when, you know, since we're in the ER, we're usually facing normally, and we deal normally with a lot of the, you know, NYPD, whether it's patients that come in just with these accidents outside of just EMS workers. And I always relay that information to them every time they come in with these individuals that are injured in that way. So I would love to make, you know, a larger impact if I possibly can and join some of those meetings as well.
Excellent. Thank you.
I was just going to respond that at least 99% of all deaths and injuries from pedestrians are due to cars and trucks, and it's not even close. And by far and away, that's the number one risk to pedestrians. As far as cyclists going, you know, quote, the wrong way, I think, you know, let's try to think about it from the deliverista's point of view. I guess you live on First Avenue. Let's say you're on First and 26th, and then you need to go to 23rd Street. What do you want the deliverista to do? Do you want them to go? I mean, they're under tremendous pressure to produce. So you want them to go, which way does 25th go? East. You know, I'm going to go
East to west.
Yeah.
east to west. So they have to go up to 26th and then go west and then go back to Second Avenue, then go back to 23rd. Nobody's gonna do that. The system's set up for them to
Because they're
fail.
also timed. If they're late by
Timed, yeah.
one
Mhm.
minute, they're fine. They get blacklisted. They don't get any other deliveries. And that, yeah, and they're living, barely making by.
They're barely making by, and a one-way bike lane makes about as much sense as a one-way sidewalk. So it just, the roads are designed for suburban drivers to drive fast through our neighborhoods. That's just the way they're designed.
Mhm.
And like you said, it's pay homage to the car, even though 85% of our district doesn't have a car. So I just urge you to kind of keep the broader picture in mind. Anyway, that's it.
Absolutely.
Dr. Genova, I'm not sure if you or any of your colleagues were able to attend Open Data Week in New York. I know that the Transportation Committee here at CB6 works closely with the DOT, but they do have a lot of, when you mentioned micromobility, they have a lot of really insightful information that I can definitely share and like in an exchange to help this effort. And when you said, you know, the data and where it's coming from, CDC is more nationwide based, this would be more specific to New York City. But I know that there are other resources to help state this case is really important and needs to be shared to our constituents as well as people citywide.
Absolutely. No, that'd be great. And I know right now we're working on trying to build out like a community facing repository for even more information on, harm prevention, even outside of just bike safety. So any and all more information data, we're trying to pull as much as possible. So that would be very, very helpful.
Go ahead, Sue.
Just a question of medical prudence in the real world. Certainly if you lose consciousness for even a second, then you want to go to the ER, but you seem to be encouraging people to go, even if they don't lose consciousness, if they sort of hit their head. I don't think that's real world. What we used to be told anyway is that stay awake for 12 hours and somebody observes you, and if there's issues at that point, you go to the ER. Do you disagree with that?
I understand what you're saying. I think I unfortunately may just be a little bit more biased just from what I've seen. And I think it's because I've seen those individuals that maybe that the ones that don't come in, I don't see, but the ones that do come in were the ones that have come in maybe on day 2 afterwards because they didn't think it was that big a deal, and then ultimately developed worsening symptoms. And it could have been something that was found on that initial visit, and we could have got there a little bit faster. But I would say, I mean, obviously, too, like I said, I also had the caveat just to say, like, everyone knows their body better than everyone else. So if you feel like anything is off at all, I wouldn't even hesitate, even if you don't have a scratch on you. But you're right. I think with the head strikes, it's a little bit difficult. If you didn't actually lose consciousness, it's a little bit tougher of a call on your end. The whole stay up 12 hours, make sure you're okay thing. I used to think that as well before I went into medicine too, but ultimately, it's really just not the safe way to go about it because I've seen some of these things develop over the course of days to even weeks sometimes, which has been very rare, but I've seen it and I've seen kind of the destruction that it causes even from a small little hit on the head. Like I would see no injuries, really, like no scratches, abrasions, anything really over the head that's too concerning that would develop into intracranial hemorrhages and bleeding around the brain. So I think just by me have seen a few of those, I'm a little bit biased in my answer to say that, I would caution you to say come in anyway. But again, I can't force anyone to come in. So, if you feel like anything's off with your body or you feel like you're fine, it's largely your call. But I would caution to say that if you hit your head at all, just go in and get evaluated. Because then at that point, if it truly is minor, with the physical examination we can do to make it as thorough as possible, we can try to tease some of that out depending on if we actually need a CT or not going forward. But I think
And
it's best left to some of the medical providers. Yeah.
It'd be an ER, not a walk-in clinic.
Yeah, ER. Yeah. I would, because the walk-in clinics, more often than not, if you go to an urgent care, if anyone's been there and been sent to the ED, you'll know that they can do that frequently. So if you go to like a walk-in clinic, I would almost guarantee that your length of stay would probably prolong itself by hours because they'd probably end up sending you over to an ER anyway at that point.
Any other questions?
All right, well, Dr. Genova, thank you so much. This was really, really helpful. And yeah, this was great. There was a lot of things that I it blows my mind, some of the statistics, because I would have I would have gone with congestion pricing has made a difference, or bike
Yeah.
lane has made a difference, and it's all, yeah. So thank you very much.
Thank you
No,
so much.
absolutely. And thank you all for giving me the opportunity to speak with you all. It's been great talking to everyone.
Yeah, thank you.
so much.
Yeah. All right, so moving on to our second agenda item, it's a presentation by NY Connects Manhattan on their services to connect people to long-term services and support, and we have Carmen Rosa here for that.
Hello, everyone. Hi.
Hi.
Are you the one?
Yes.
So I will be giving you guys a copy of the presentations yourselves so that you guys can have the information at hand. I also do have resource packets. Some for housing, some for geriatric and mental health care. This doesn't have to be just for you personally, it could be for someone you know, or if you've encountered a situation. Here. So, hello, everyone. My name is Carmen Rosa. I'm the outreach specialist in New York Connects Manhattan. I will just be explaining more of New York Connects Manhattan and the programs that we do offer, or the services that we do offer. I do have, can you take one and pass it down? Thank you. Take one and pass it down. So, who are we? Great question. So we're part of a statewide program to get people connected to services and supports. This is a statewide program. So this is part of basically an extension of all 50 states to get people who are older adults or people with disabilities connected to services in more of a streamlined way. So what does New York Manhattan have to do with this? We provide free information and assistance to support them in making that decision. So connecting people to promote independence or well-being, or anyone has been an older adult or has encountered an older adult or worked with them, you know, the concept of aging in place. That is one of the things that we do help to maintain with independence. Another thing is we do offer personalized guidance in having the trained staff, so us as a specialist, me as an outreach specialist, in the assistance on people's specific cases. Next slide, please. So who do we service? We service a lot of people. So older adults, 60 and over, people with disabilities, the caregivers, friends, the professionals. If there is neighbors, friends, basically everyone. I do mention a lot of it in a more condensed way, but we do. Next slide, please. So what does that look like in terms of what we can help with and how we can help? So this is just an inkling, a droplet of what we've done. This doesn't even cover some of the personal calls we've gotten or things we've helped with. So some of the things could be home and personal care, housing support, transportation, benefits and entitlements, think Medicaid, Medicare, Social Security, disability, and retirement. Behavioral health services, the ombudsman. Ooh, if anybody has a loved one who's in a nursing home and they're like, hey, I hate this treatment, we give you to the ombudsman. And that doesn't only have to solely relate to nursing homes. There's also ombudsmen who are independent agencies, whether it's those with IDD, intellectual and developmental disabilities, if somebody suffers from addiction or mental health issues and they're trying to navigate insurance, there is an ombudsman for that too, just to name a few. So how do we help? So there's a couple of things. One of them is connecting people to local services and programs. Another one is exploring options. So that looks like one of the things is options counseling. So if somebody says, hey, Carmen, I have so many issues, what do I do? This would be an options counseling kind of situation where we navigate basically saying, hey, X person, here is the set of resources that would best apply based off the topic. And based off of that information, you have the opportunity to make more of an informed decision of what do you want to do. Another thing could be something as simple as applying for benefits. Again, Medicaid, Medicare, Social Security. I've helped people with SNAP benefits and Social Security retirement benefits. And again, remaining independent and aging in place. So if somebody is just like, hey, I just need a home health aid and I only have Medicare. Well, in New York State, there's something called ISIP, which helps with providing home health aids. And this will be covered by Medicare on a sliding scale. So that's one example. Next slide. So what differentiates us from all the other numbers you got in your tool belt? Great question. So for us at New York Connects, if you are just wanting information for services and supports, if you just want to connect people to something, or you're just trying to look at all the options of what there is in the city, that's where you call us. If you're looking at more city agencies, if you're looking at reporting non-emergency issues, so like, hey, there's a pothole, what the heck? 311. An emergency, we just had a presentation with NYU Langone, and the first thing I said, contact 911, 911. That would be all the emergencies you could find, you would contact 911. Lastly, 988 is for mental health crisis. So if someone's feeling suicidal, if somebody is not feeling their best, they're going through a lot of stressors, whether it's death in the family, financial constraints, and they're feeling that mental pressure, 988 has trained professionals who are in the mental health field to assist them. Next slide. So examples of long-term services and supports. So help with bathing, meal prep. If people are looking for home delivered meals or medically tailored meals, hey, I'm pregnant, I'm about to be having a baby and going postpartum. There's medically tailored meals that can cater to that so that people can have those things catered. There are certain exceptions with some organizations and they may be limitations, but there is meal preparation, bathing and dressing. Home health aides, personal care attendants, that could be covered largely by Medicaid. But again, Medicare is an exception with the ISA program that's within New York State. Transportation, medical or non-medical, think of your senior ride buses. So we are in CB6. So this would usually be under Project Hearts, under the New York Foundation for Senior Citizens. And that is funded partly by donors, donations, and DEFRA. If people are interested in senior centers, they want to socialize or they want to do friendly visiting, there's options for that, whether it's DeRoe, whether it's your local OACs that are funded by New York City's Department for the Aging, and getting connected to any activities, intergenerational work, or if you want to do dancing, Zumba, things like that, or if something more simpler, hey, I need adult diapers for my loved one. OACs have a lot of them for you to get for free if you're struggling with especially insurance covering it. And medication and finances, those are more simpler. The finances, there's more robust services in relation to that to help people with money management. But the medications, it depends on the place and the facility, but it can be something as simple as getting translation services for your medication. So if somebody is like, hey, I speak French Creole, I don't understand this English, you can get that kind of thing done. Next slide, please. So scenarios, I will go through a couple of them. I may speak on more personal experiences that I've dealt with. So for example, Maria, she's 78, she needs home care, she needs transportation, and she needs help with managing daily chores. Us and New York Connects, we would get them connected to apply for Access-a-Ride and connected to a home health aid agency. It doesn't have to be solely one. We give the option of having at least 3 to 5. The exceptions is if there is certain things that are very contained. So for example, think NYCHA. Think if you got rejected by your health insurance for a procedure or something, that would be within the insurance provider. And it would help with improving her safety and independence. Another thing is Tanya, 67, she is looking for assistance with affordable senior housing and home delivered meals and legal assistance. So we get her connected to agencies or providers, whether it's, for example, Whole Community Incorporated, whether it's Phipps Buildings, whether it is Goals, the good old Lower East Side, whether it is Home Style Direct, Mom's Meals, Meals on Wheels, and things like that to get her help with avoiding eviction, getting her some emergency assistance that she may need, and even like getting some representation. Next slide. So again, those were previously just more generic examples. We've had very elaborate issues, whether it is someone who has struggled to find assisted living facilities and they're under the age of 60, which can be hard to find, and they get placed in a shelter. I've helped people with Social Security and applying for their retirement benefits, and they've been over the age of 65 and they weren't able to get those benefits. for their personal reasons. I've helped people with their SNAP benefits to get it. Another thing is for people who are looking for care management. If you're someone who struggles with going for scheduling doctor's appointments, scheduling, for your pharmacy deliveries, things like that. Care management is another option or alternative for people who may struggle with that day to day. That can get covered by Medicaid. So they could get that done through a person and they could still get the things that they need to meet their more social determinants of health. And this is, yes, the phone number to call us is gonna be a 212 number. There is an email, this is also the referral form, and I can definitely send this after the presentation. It's a Google Doc, it just goes over the things like, hey, what does this person need? Can we contact them, or are we just contacting you? And that's all. Any questions?
What's the, are most of your clients, if that's the right word, lower income? And I mean, the reason I ask this is because there's, I don't think it's good for the donut hole, but you know, when you're middle class or middle income, you sometimes struggle harder to get some of these resources because you don't have Medicare, you only, Medicaid, you only have Medicare. And so in some ways, it's a greater challenge. I'm not, you know, bad for people who have more money, but it's a question.
So we don't have that data in terms of the income distribution amongst the callers or individuals we help. In terms of the information we do provide, we like, for example, like, hey, Bob, what is your income? We don't really ask that. It's more like, for example, if a legal firm only assists people with this income and below, we may suggest, like, hey, do you make less than X amount? It's never tailored to just like income. We work with everyone and whatever resources we don't have immediately on hand, we do work to develop.
And how do people, I mean, maybe this is why you're here, but how do people know about you?
Well, I am the outreach specialist, so I've been like,
Do emergency rooms, do police, who refers to you? Who refers clients to you?
so it's a mix of things. It's never one single thing. So we've had people call us because they've seen us in an ad in Chinatown. We've had people refer us from city council members, state senators' offices, professionals, other social workers who are like stuck and they're like, I don't know. People that may just know through a friend, they're like, hey, I really like Carmen and the work that she did with me. Let me refer. It's just very random. Those certain communities may be easier to get to than others because of familiarity or because they're very like, hey, we got it until they don't. And then from there, it happens. So for me, it's encompassing all of Manhattan, not just solely uptown Manhattan or only lower Manhattan. Is like everywhere in Manhattan. And whether people decide they want to get the services and supports, that's more of a personal decision after a while. Any other questions?
Just to clarify, this is probably a stupid question, but New York Connects, it's just to connect with other services that provide these services. New York Connect does not provide housing or
We're
home
not
care,
a
transportation.
provider.
It's just connecting to other, it's just like facilitating other people what options are available.
Yeah, we also
Yeah.
do get information ahead of time of the general public. So because that we help people navigate where to go, or rather navigating where to go next. So like, for example, the changes with the home health aides in New York State. A lot of people were scrambling, hey, I'm a caregiver for a loved one, where do I go, where do I go? And then we had the information ahead of time of the general public, so we just got them to where they needed to go. I had a case where older adult man, he lived in Manhattan, he was caring for his cousin who was on an electric wheelchair, and he can't just be anywhere with her. He needed to get paid, he was behind on it, and for me, at first it was like, yeah, I have the information, but I ended up facilitating that call to get them to someone faster. Other times, for example, actually, I won't say this one. I won't say that one. But there's other times where I've just merely helped them to get them connected to someone else who would be better off. So like, for example, utilizing your politician's offices. Yeah, I helped somebody with their social security retirement application, and even on social security, I meant, and they're like, hey, this was good, this was fine, but they didn't get their checks. So now, hey, you live in this district with this federal rep. Let's send a referral out so you can get that quicker, because they know how they can streamline it to get you that money faster.
Sorry if there's another dumb question, but do you go to like homeless shelters? I assume there's a lot of need to connect with services at homeless shelters. Do you?
We get calls from homeless people because they're in a homeless shelter and they haven't gotten help.
Yeah.
That's
I
how
would,
accepted.
I would think almost everybody in a homeless shelter needs to connect with multitudes of services,
That depends
from
on the
mental
shelter.
health to housing to
That really
healthcare,
depends, so we
food.
provide more case assistance, shelters, depending on what it is. Some are more extensive in case management, so they can be like, hey, Bob, we're gonna work together until you get a house and get out. And then some are just more hands-off, like, hey, you need to do this independently, so they may not be as involved as a participant. As a result, we do get calls from people who are in homeless shelters or about to be in homeless shelters. And we do try to assist them along the way, but depending on the scenario, we do try to get them somewhere else, so like a warm transfer to someone who can help them more extensively, so they don't go, hey, what happened? I'm just left to work on this by myself. So for example, I had a person who referred me to an individual. No, the opposite. They referred someone to me. And they were in a homeless shelter, but it wasn't structured as a traditional homeless shelter. They had like a limited time to be there and they needed help they managed to get an extension on it. And they were like, hey, I need to look like I'm actually finding housing or trying to find housing. And as a result, it's like, hey, so here's some places that are doing affordable housing. So this could be like nonprofits, this could be private developers who work on building affordable housing. That's why I mentioned Phipps Buildings. Clinton Housing is also another one that does it. Not to be confused with the NYCHA building that is set up in that similar name and vein. Another thing that comes to my mind is, yeah, there's definitely the Housing Connect lottery one is another one that's more the most known, but the other ones such as Hope, Phipps, Acacia, HCCI does it. So there's a number of places, so I did give her that information, and from there, she was able to determine like, hey, this was great, thanks. And also housing ambassadors. Housing ambassadors are volunteers from organizations, whether it's Goals, whether it is 116th Street Block Association, that can help to prepare your application, send it out and help you prepare for the interview when it comes to housing lottery. So you're not just like, hey, I'm doing this, so what the heck?
But you guys aren't doing like coordination of care for all of these services. It's more like you're giving people a list of referrals and maybe an introduction.
Not a list of referrals, we can do the referral. So like, for example,
Uh-huh.
somebody has a disability and they're like, hey, I need help trying to navigate getting all these benefits.
Right.
We could do a referral to Sydney, the Center for the Independence of the Disabled of New York, and they
Right.
have offices in all 5 boroughs. Another thing is, for example, if somebody is getting out of a hospital, maybe they had a care transition plan, though probably maybe not the most preferable, we have options called the back home tool, which we do ask a series of questions that is protocol to get them that assistance. So for example, I had a colleague who had a individual she's been working with extensively, but she has a number of issues and she had an upcoming spinal surgery. That's a lot. One of the issues is that she had issues of coverage. So they were able to get consent to do an emergency. They were able to try to work on getting them an emergency SNAP application completed, so they can have money for food to take care of themselves. And they were worried, they were like, hey, I also have an issue because my building is not the most ADA compliant. Call Sydney, call the Center for the Independence of the Disabled, call New York Foundation for Senior Citizens, because they can work on things like whether it's home repair, whether it's trying to build the ramp and things like that, or if not, they will do advocacy to get on those landlords. Heights. And deal with it.
Thank you.
Brendan?
So I'm fascinated by how you brought up that some elected officials' offices have reached out to you all for referrals or receipts, et cetera. And, you know, offline I'll need to explore whether we have any cases where, any constituent service requests where we should do that. But very basic question, if there are any such cases, should we reach out to you or just fill out the referral?
Reach out to us, fill out the form, you can email, any way, which however you want, reach out.
Okay.
Like, yeah,
Is there any way that your experience and maybe you have metrics informs policy? So that, for instance, you know what the needs are, you know where budgetary needs are lacking. Does the city listen to you at all? I mean, do you feed any information back?
indirectly, yes. So for example, one of the things we ask is information, demographics, so name, last name, phone number, DOB, address. People can refuse to consent. There is some exceptions also, so like if somebody is a victim of domestic violence, we do anonymize them for their protection. And one of the things that we do with that is it gets notified to DIFTA like, hey, if people have this much issues, probably we need to do more services related to that. An example, we get people who are older adults, they may need grab bars, they may need certain things, grab bars, handles, any extension to fix their apartment because they're older, they may not move as they're not as agile as they used to be. And there's a number of places, so think of the Met Council, the New York Foundation for Senior Citizens. Now, DIFTA, through a grant from HUD, has their own minor repairs to assist for seniors. And they do it on an income basis, so people will need to check their income for that and apply, but it can be done for free.
But this occurs because policy is informed by the work that you do, or?
Not policies, but more of like a constant, it's an indirect feedback. So if like 20 people in this room all have an issue with housing. Not how much. And all those 20 people are in this area and this is the only amount of people and they all like consent for information, that information does eventually get to DIFTA. DIFTA is part of the city agencies, so they can see, hey, these older adults in these areas are being impacted by housing. What services and supports do we need to do, or what programs do we need to curate to get them those services and supports? In terms of the politicians' offices, this is where it's tricky because sometimes the information or issues they may have, we have to. So I'll say an example. I met with the state senator's office and your local politicians' offices will curate, they'll fill out forms to make sure like, hey, what's the general trends of stuff? So it's never out of reason. Out of 200, including they got 160,000. And for us, even us, the general trend, some of it can shift. So like last year, there was the government shutdown, there was concerns about SNAP benefits. Sometimes those end up being one-to-one in terms of the information. So yeah, we deal with a specific demographic, people with disabilities, caregivers, older adults. But a lot of times they can overlap because that's how constant those issues are. I hope that was helpful in answering the question.
Let's do that.
Department for the Aging, so that's under New York City.
Great that you're here. I'm a resource person and it's kind of like, it sounds to me, I used to do case management. It sounds kind of like a bridge between facilitating different resources and actually like getting people connected to the right people, grants, whatever it is. I'm just curious, if you said it's a statewide program, but we're talking about Manhattan, specifically our district. Of the information had contact you, do you have like yourself, someone who's specific to each district of Manhattan, or like people who are located in the city that know uniquely city needs that
So there's-
level up to different agencies and resources that you work with versus those that are throughout the state and working with different demographics, different New Yorkers?
Let me see if I can answer that properly. So there's an office in every borough and every county in New York has their own New York Connects. That is funded by their either Department of Social Services or Department of Aging or any agency on area of aging, AAA, and they work on their community and area. So I'm in New York Connects Manhattan. We see all of Manhattan, the concerns of Manhattanites or people who have loved ones there or who are a caregiver or a professional who has a client who does live there. So the resources either cater to Manhattan or they have offices in Manhattan that do cater to people there, or they have programs that are exclusive to that. Was that helpful? Okay.
Any other questions?
How many people do you connect in a year?
That varies. So
Ballpark.
we've worked with like several thousand over the course of 12 months, but we're counting not on a calendar year, a fiscal year for us.
Mm.
So it's a little different.
And they're all so happy.
I know. That's so great. Happy workers. I think this is great, yeah. But, you know, and I know you're out there doing your job, and I believe that, but more and more people need to know what's
Yeah.
available. I mean, that's the hardest part of all of
A lot of
this.
times you don't even know what options you have because you don't know that they even exist. So, yeah.
I find that, with working as an outreach specialist, there is a rewarding factor to being like, oh, my God, I'm not 20, like I meet you. One of the things is like, just how niche everything is. So unless you know someone who knows someone, or you're in the right rooms, it can get lost in translation. So being in Community Board 6, it is a privilege to be here. Again, thank you. It is also very, very well resourced. So it's sometimes harder for people to be like, oh, well, I don't really need that. And then time comes and they're like, well, I'm up Schitt's Creek. So it is a different navigation. One, how open are people to just having that information for resources and supports? It's also a cultural thing. So I'm housed in Chelsea, so it is a little bit of a different kind of historical landscape. We're in Midtown East, so it's a different kind of landscape when you're looking at it. Places like Bellevue, things like NYU Langone, Mount Sinai, they take on different powerhouses in that area. And that also determines whether people like, do I really need this or not? And that does change the way things are handled. So New York Connects, we do work to get connected to everyone, regardless of income, background, immigration status, and things of that nature. It also does speak to the challenges that are ahead in terms of getting to everyone, both on people knowing us, but also people being open to knowing about us.
This board has recently discovered, what are the kiosks called? The,
Link NYC.
do you publicize your services on those at all?
That I haven't known about, I know about Lincoln.
That was just a suggestion then.
Yes. But I don't know if previously we have done it.
I believe as a city agency,
Yes.
you can advertise on that like a specific number of times for free. You just have to get connected with the right people.
Yeah.
Rupal, I think that service is free even to, like, you know, I know MV for New York has advertised on it. Didn't pay anything. It lasts, I think you get it for 24 hours or 48 hours, something like that. So I don't think there's any cost to advertising. You just have to fill the forms and get in the queue.
Yeah,
So might be something to consider.
I'll definitely consider that suggestion, yes.
Just to be explicitly clear, because you mentioned DIFTA, you mentioned on your slides, it's 60 above is your main focus.
That's one of them.
However, it sounds like open to all for resource allocation.
Yes.
So just want to be really clear, because we have a diverse, population in our district as well as Manhattan across the city, but I just want to make that clear, like, is it specific to the 60 or that's most common, but it is open to everyone?
It's the most common.
Okay.
So this is funded by the Department for the Aging, but one of the programs, not programs per se, but systems under New York State is no wrong doors system. So if somebody needs assistance with anything, we can't just refuse to help them just because they don't look 60 years old, just because they don't look disabled. Whether we can't assume, we gotta help to streamline those information to resources in a more effective and affordable way. So for example, so the downside to that is some of the resources are gonna be age specific. So if somebody needs money management, I'm not gonna give them a DIFTA program if they're 45 because they're under the age of 60. That's a kind of a sabotage. The other side to it is if they do qualify for something and they're within that range, we definitely do ask for that kind of information, like, hey, are you within this range? More general questions, and then we can connect them to those services and support. That would be helpful. So again, an example of this, if somebody is more well-resourced, but they're like, hey, I do want home health aid, but I just want to see what's my options. There's a couple of options. One of the options is if you're looking at ISIP, I said it a million times, but that's one option, and they can do it through the case management agency that is within their district. So I think for 1, 2, and 6, it's gonna be under New York Foundation for Senior Citizens as an example. But if they're like, hey, no, I wanna do Medicaid, a pooled income trust. So NYSARC does trust services, so you can have that money that you've made, your pension, your retirement, or any other kind of income you've had, put that in a pooled income trust, so it can lower the amount of income you report. And you can use that, and it won't affect it, so you can use it to pay your bills, your rent, and mortgage, or whatever you do have, and you could have Medicaid. That looks like you're like, I am intrigued.
I'm listening and learning.
So that is an example of that. So for example, I helped someone in the constituent clinic, and he assists his sister. He is a caregiver for his sister, and his sister has dementia. He put her money, and he has power of attorney and healthcare costs. He does work with his family, like his brother. The sister's husband had passed the day before I met him, so not the best situation. But he did want to look more into the nitty-gritty regarding the trust, the pooled income trust that he was already trying to utilize for his sister. And from there, I did call NYSARC just to verify, so I can know how to word the language of pooled income trust and assets and things like that, because that can be very wordy. And just try to relay that information and utilize NYSARC as a resource for him. So since he was POA and healthcare proxy, it didn't make it easier. Another thing, we do information for legal services. This is not limited to just housing. I did mention housing. This could look like POA, power of attorney, living trust, estates, elder law. If we do have a resource for those who are still survivors of 9/11. So if anybody is interested in that, I still have that information. We also do continue to work on building information that we do have. I am an outreach specialist, so I'm connecting with providers, I'm connecting with agencies and organizations to know them just as much as they know us. So we know how to utilize the resources properly. One of the examples that comes to my mind is New York Common Pantry. So they're very known for obviously food pantry. They do also offer case management to help people get assistance with SNAP benefits. If somebody suffers from mental health issues and they need supportive housing, that's looking into 1020E. Yeah, 1020E, and they can also help with finding housing related to that. So those who suffer from more severe mental health issues, that's one of the things that comes to my mind. Yes.
Okay.
Excellent, yeah. Thank you, this was excellent, yeah, thank you.
Night of lots of good
Yeah.
information. Everyone's gonna have to watch this meeting.
Ms. Moving, do you have any questions?
Nope, good.
Alright. Well,
Thank
Carmen,
you for
thank you so
waiting.
much
Yeah,
for
thank you
coming
so
over
much.
and sharing all of this information with us.
Yeah.
Again,
Sure.
thank you for having me for the community health fair 2 weeks ago, so I just want to say that. And if you do have any other questions, comments, or concerns, feel free to reach out. Again, my name is Carmen, like San Diego, like a legend of like opera. Like I got, I'm the outreach specialist, I got speaking all the rest. I'm like, oh. It's like, I know who I'm getting to. Thank you.
Thank you very much. So, moving on to the third item, the fiscal, year 2028 statement of district needs for the, youth child welfare services. We wanna pull up the responses, cause, so when we did this part for the health, there is like a overall a pretty, major consensus, like most of the members agreed on mental health. In this case, we don't really have a consensus. So,
We only have two responses as well.
Yeah.
So maybe there.
And you had responded to an email
Mhm.
and just for other people's, I had reached out about this, anticipating this conversation. I was asking like how you can submit, because the way that we submitted for the health go around was like through a document or via email.
yeah.
So I think that just
This was
wasn't
email.
quite clear of like
Oh.
how to submit.
Oh,
for
so
someone
we're
to-
just gonna do the same thing
Okay.
as we did for the health, except we had a different list of options.
Yeah, and I think the list of options was also unclear for this versus for the.
Okay,
Those were the two things. that I
okay,
was
so
trying to get.
do we have that
Clear.
document?
It
pulled
was
up?
an attachment.
Did
to
you
the
get
last-
mine?
Yes,
I'll
Yeah.
share that in just a minute.
yeah,
I'll put it on screen for those
It could
watching
have been an
at
attachment, but
home.
it felt so long ago, that's why I was trying
Yeah,
to get the most.
Yeah.
updated information.
yeah.
Zoom in a little bit.
Yeah.
And this one, the one highlighted in yellow is our current pay.
Brandon, do you mind doing her a little bit so we can see the focus? Thank you so much.
I pick all of them.
What is the category educational attainment?
Needs bringing up the
High school
level of,
graduation, right?
well, it could,
Amongst
yeah,
others.
it could be that, or it could be reading and math
Right,
levels
right.
too.
The
But-
quality of, or at least the results.
Yes, the outcomes, yeah.
I think I missed where we were supposed to email you or,
Yeah.
I think
Yeah, that's right.
I must have,
That's fine.
well, I would have emailed you, but it'd be interesting to see what everybody's
Yeah,
top interests are. And we have two of them,
I think
which looks
it's,
interesting.
yeah, so, I had picked diversity.
Okay.
And then Katie, what was your response? You had,
I picked, support services for special needs.
was Brendan on that email or was it just me? I can't remember.
Oh,
Both.
I must have.
Both.
Okay. So, yeah, and then there was another response as well, but yeah, so I mean, like I said, we can just kind of figure out, like, if we can figure out if everybody agrees on something, then we can do the same thing as we did last time, which is write the blurbs and everything, yeah.
The other thing is that regardless of which one we pick, we can include others in the narrative.
Yeah.
as we
Yeah,
go,
exactly,
Because there's
exactly.
a lot of overlap.
Exactly, a lot of it is over,
Different
a lot of it is connected, we just have to
Yeah.
kind of pick one
The
that we
focus.
kind of put at the top, but that doesn't mean we can't, in the blurbs. Put in a few other things,
Right,
yeah.
yeah.
Or sneaky. What do we know? I mean, before, I know reflexively what I'm interested in, but what do we know about the conditions in the district?
Yeah.
So that was something that Katie and I had spoken about, so I don't believe we have the time, but correct me if I'm wrong, based on the timeline for when we have to submit everything, Brendan. But Katie did wanna do more like a survey of either parents or schools, or, some people who are actually impacted by this. And actually get their input on what they feel is what we need. Because I don't have any kids or anybody I know with kids in the school system. I don't know how many other people do, so my thing is just based on my instinct, I guess, or what I've heard. but that may be very off. So, but since you have the deadline coming up, we don't exactly have the time right now to put out that survey and get feedback and then figure it out. So that may be a strategy we want to use next year's, but district needs statement, but for this year, yeah, we kind of, because I think we have to submit this, what was next month?
Because we have a summer hiatus.
we have
and
it till
then
October.
we have, a pretty short runway in the fall to get this public.
Yeah, you're on the budget committee, right?
Oh, I love that you think I am. I'm like,
You are.
On the budget
You
committee.
seem to have all the answers, so.
No,
We
no,
want
no,
it from, we want it for May, right?
Oh, okay, yeah, that's what I
Yeah.
thought, yeah.
Before the summer break, well,
Yeah.
not for ball.
Yeah.
So-
I don't feel comfortable just making it up though.
Okay.
And there is data online, right?
Yeah.
There's the, whatever the schools
Really
was.
went through, I feel that, you know, we should really do outreach to the community to understand, you know, what people living in the community see as a need, because we're not elected representatives. So what we're doing now is just sort of, what do I care about? What do I know about? And none of us has like a whole lot of knowledge about, you know, this area. But I did like so, you know, because of the time constraint that we have, I did really look at the data. There's a ton of data in those books over there from the, what is it that?
Yeah, I remember that and I don't.
Yeah,
think
so I really
still
use,
one now.
yeah, and the great thing is it's the Citizens Committee for Children of New York. They have all of the data broken down by community district, even the education data. And so they have some of the data in this book, but they also have a website, data.cccnewyork.org, where they have tons and tons of data. So that's the data I use to pick my option, because I looked at our district is one of the most well-off privileged districts in New York City. And all of this data, when they, you know, do it by community district, they're really comparing the means of the different districts. So we have very high means, but within those means, we know that there are people, you know, who are at the bottom, who need help. So what I was trying to see, like, but just looking, you know, at the data of the means, I saw that the things where we weren't like much better than the rest of the city were in terms of the percentage of students who have an IEP for a disability. We know that children of immigrants are under, you know, terrible pressures right now and need a lot of assistance. We also have Baruch College in our district, which has a lot of non-citizen students. And English language learners are throughout the city. They have had higher rates of high school dropout. And we have a similar percentage of children living in temporary housing, so homeless children to the rest of the city. So I thought those are the special needs populations. So I thought that, you know, we can say that we really, you know, want those students' needs met, and we can fold that into like in ways that foster diversity and inclusion. And, you know, we can even bring in like even the class size maximums, which will allow, you know, teachers to really, you know, meet the needs of children with special needs in a way that doesn't segregate them. So,
Go ahead.
Am I the only one that put kids through the New York City public school system in this district?
I don't have any kids,
Did you?
so.
Anybody?
It's just you,
Just me who
Oh,
put
you do?
kids through schools in the public system?
the freak in the group.
Yeah.
so you're.
Because,
Really, I have
No,
they
it's
don't
They're not-
go in this district.
oh, they don't go to
They don't
schools.
go to
Okay. it's funny, listening to everybody who doesn't have kids talk about it, but the school capacity is a massive problem in our district, and you saw it spill over with Salk. As Salk's getting kicked out of PS40 building, and you know, people are worried where my kids are gonna go to school, is there capacity from, so I saw somebody actually wrote that, I don't know who
Yeah,
wrote that.
I did.
Oh, that was awesome. And I was like, yeah, that's like the number one, that's what I would vote for, the number one need in our district. And we saw it explode in our own community board.
There's another educational crisis in hand, and that is qualified teachers getting them.
Right.
Because with the smaller class sizes, and the mayor has said he wants lots more teachers, but where are we gonna get those teachers?
Well, I think that's
Qualified
also
teachers.
in,
So it's kind of
implicit in
capacity,
capacity,
qualified
because-
teachers.
right, because you not only.
It also
need
needs
space,
a
but-
special,
yeah.
so we can probably
It's tough,
pick something,
yeah.
and work a lot of things in. But if you
Yeah.
look at the crisis in the city right now, it probably, you know, is teachers, so that's probably around
Yeah.
the world too.
If I could say
And
it's space, there's no space. Like, even if
No,
you
it-
had the
it's
teachers,
just-
there's no space here.
Space, like I went
Space is
to
big.
a CEC2 meeting. And they were saying that, you know, there's been a decline in the student population. So there is empty space. It's just, you know, using that space in a better way. Like there's a downtown middle school that they're actually closing now, and they're thinking of putting in a new kind of specialty high school around AI. So,
But in our district,
Yeah.
there's no space.
well, this is District 2,
Oh, it is?
we're within.
Oh, District
Right,
two.
District
It's
two,
Education
that's,
District.
Oh, education district,
Right.
okay,
Yeah,
okay,
so
but
that's-
District 2 is huge.
District.
Yeah,
two.
District 2 is huge.
Huge,
Yeah.
Education District 2
Yeah,
is
but
huge.
that's our school district.
Correct.
Just because I know that this is a very important subject, but we don't have a lot of time tonight. I'm just curious what we had last year.
We had-
Just
we had
as-
maintenance.
It's been highlighted in yellow.
I mean, at the actual, like, statement that was made last year.
It's below.
Because to what you're saying about like integrating some of the, I guess, the things that are on that list that intersect, because child services is the mayoral agenda, so that we don't, it seems obvious that a lot of them do intersect with each other, but when we're talking about capacity, I was just thinking maintenance capacity, they might have touched on that in the previous statement, so I always go to like, what did we do
Yeah.
It was
before? and
mainly
try
about,
and-
like, as you can see, it was about HVAC, plumbing,
Right.
playgrounds. So
And
it
I was on the education committee last year, and we didn't work on that at all.
Okay.
I think
Well, it
that
was
was
a different-
something
it was a
that
different
John
process.
wrote or
Yeah.
picked it from the previous year.
Could have been.
We didn't work on the need statement at all.
Yeah, no, this is a different agenda from last year. I was just curious if there was anything that,
Oh,
to your
this is
point,
the-
and
It was the
Right,
same,
they
it was
just,
the
took- they just
same,
repurposed
Right.
an old one for the next year and the
Yeah.
next year and the next year, so this is like
Yeah.
the first time we
yeah,
tried to
because
refresh it for a while.
last year on the education committee, it was really kind of a wreck. Like we had, I think, 3 different chairs and I don't know, it was pretty dysfunctional. So we didn't do anything with the statement.
Stu, I feel like you want to have something to say.
Oh, it's fascinating how you. What's most amazing is I had nothing to say.
this.
Maybe it's all for nothing.
All right, so just, you're, can you pull up the list again?
Sure.
So, Katie, which of those was the one you picked?
Support services for special needs. youth.
Okay, support services for special needs, so that's
Right.
one. And then we had, the one you had picked, which was the capacity. So that, is there any others that we wanna look at as the priority, or do we wanna
I think that the adolescent substance abuse.
Okay,
Do we wanna highlight?
yeah, can we either highlight or color, yeah, just maybe add a different color so we know which ones to look at.
Maybe green or.
Yep.
No, that's.
No,
not-
add
not what I want.
yeah.
Pretty.
So that and support services.
Didn't you use diversity?
I did, but I think diversity can be incorporated in one of these other things,
Yeah.
so
Yeah,
I think we
definitely, yeah.
can like take that one off. You said,
The
adolescent.
adolescent substance abuse.
Yeah.
Could you elaborate on that? Elsie?
I think we can get some stats on that from DOH.
But right now for today, like why, like what's your reasoning for picking that?
The rise in the use of cannabis among adolescents.
Okay.
Well, there have been, just coming from the bulk perspective, there have been a lot of community members, particularly from schools, educators, concerned parents, talking about the proximity, policy and the concerns of the advertising and just the proximity in their, what do they call it, the transportation corridors in our district that are close to education centers and schools. So I don't know if that was something that,
Well, I think, I mean, if it's a
Helps.
need, like the need would be, we need X services or we
We
need.
need to educate, we need to
Mhm.
create more programs for educating the adolescents about the use of cannabis.
yeah,
I would say having raised two daughters all through their, through, from the time they were kindergartners all the way through high school into college. I think as a parent, I certainly saw tremendous proliferation of not only, inappropriate substances off campus, but on campus. And each year, the incidence of inappropriate use within the school system used to go at, it used to be high school, then it trickled down into middle school, and now it's trickling into elementary school. So I think it's a chronic and important issue. One, because we have a proliferation of smoke shops and cannabis shops and other stores. Even the legally licensed stores, there's a tremendous proliferation of it in our district. And I think, the outcome should be that, yes, there should be far more education in a cool, funky way so that kids actually relate to what's being told them. Because I do know that they would have the occasional sessions at school about why smoking is bad for you, why drinking is bad for you. But the actual use in the student population, we just saw it. I don't have data, but in the actual anecdotal experiences that mothers and fathers shared on school campuses, it just seemed to blow out of proportion in the last few years. So to me, I think as a concerned parent, that is an important issue. I would certainly like to see it on the list, unless people think there are other more significant priorities. But I think this not only impacts our youth's physical health, but also the mental health, and then, proliferates into everyday living when they go out and are looking for jobs and whatnot.
Can I ask, I don't have a good enough recollection of what we put in the health part of our needs statement, but is there?
It was mental
Right,
health,
so-
so.
Okay, okay.
We were going to have the district superintendent visit us, right?
Yeah, so, that was for the Salk school, but since that issue kind of resolved.
It
as in,
wasn't
like-
just the.
Oh, it
school.
wasn't? Oh.
Yeah, no, I was
Yeah.
gonna have him talk about how we could do this,
Okay,
this kind of have these community discussions with, people in the school.
okay, my understanding was, because that was around the time the two committees merged, was that the
Yeah.
superintendent was more for the Salk school discussions that we were having.
No, it was really, I was trying to prepare for doing that.
Oh, okay,
I felt like it was really important to get started early.
okay.
Is
Yeah.
there time to do that?
This for this year, I don't believe so, because I think this has to be submitted next month. Yeah,
So I guess the question I'm
We
gonna
can
have
begin
to
to plan
the
for
staff,
next year.
because the way, again, new member as of this past year. This sounded like a different process, that each committee was gonna be more involved, hands-on, and giving us an opportunity to really take a look at this.
Yes.
The way that it's conducted, it might have been resurfacing things previously over and over again, but this seems a little bit more nuanced and curating it in a different way. What is the deadline for the staff? Because I know that Jesus mentioned this in the beginning of this process, that you guys were gonna be submitting the final copy somewhere in the fall. But what is the,
October.
like,
End of October.
Right.
the end of October?
Yep, that is the city's deadline. That's not our.
Okay, but I'm saying staff, you guys, like, what would your preferred deadline for all of this content to be finalized?
so for us
But
to give it
it's-
to you, when do you,
Cause I know you're using different committees, different timelines, like Bulk already did it, Health did it.
Yeah, just speaking from a staff standpoint, Jesus might have a different answer. My answer would be October school board, because like that is the absolute last full board meeting before that aforementioned October 31st deadline.
so we always meet after full board, so for us, it would be September meeting.
Right, but there's,
I'm still going back to, if we had the district superintendent here next
If
month.
if we can get him here, we can definitely have this discussion and get his input.
our
if-
last meeting is June, right?
In June, yeah,
Caveat that
so,
sometimes his
His-
input may not be input of kids and
It
parents.
may not be.
But it's good to have, I totally get
It,
that.
it is just one piece.
Yeah,
But
yeah.
we don't have, I mean, it's a lot better than,
Yeah,
mhm,
this is
Nothing.
how I feel
Yeah.
like.
Brendan has
agree.
something.
So one thing for the committee to consider, since there are three different possible choices the committee wants to consider. Maybe someone drafts blurbs for each of these issues. And the committee considers, like, looks at those blurbs at the next committee meeting. This is what happened with transportation recently, where there were two competing, where there were
Multiple.
two different issues that different committee members were interested in. So blurbs were drafted for each of those issues, and the committee just discussed actually earlier this week. Which of those issues and which of those blurbs to go with.
So to your point, let's say we try to get the superintendent, right? But let's say his schedule conflicts and he cannot make it. If he can make it, great, we would definitely like that input, right? But let's say he cannot make it, do we wanna have like a backup picked? Because if we don't, then I'm afraid we might miss the opportunity to even make a statement. So if we get him and we wanna change our answer, great, we have time for that. So is that something,
My answer is that if we don't have enough information to make a supported statement, then we shouldn't make the statement. I don't wanna go by reflex. I think, you know, if Katie has some, and, you know, we look through this data, which I admit I haven't done, even though I should have.
So
If we can support it, what our contention is with data, that's great. But let's not just go through, you know, I feel like,
and also the truth of it is, every single one of those things is needed. So the question becomes, I would think we'd be focusing on not maybe what we like, but what is most needed.
yeah, go ahead.
And what we can back up with data.
Yeah. Yeah,
to the data question, just being very cognizant, I don't have kids, but I know that the kids are gonna be out at a certain time, like for the spring, summer time, and our last meeting before our summer break is in June. So I
Right.
think that's the timeline we have to collect data. You mentioned earlier about wanting to survey folks or whatever. I guess my question to the committee is that competent enough time
No.
to do it.
No.
Well, then we have to,
No,
we have
we
to
have-
find a compromise, for this year's district need. Doesn't mean we can't be more robust,
Next
in
year.
doing it next year, which I agree with what you both
Yeah.
are saying, but in terms of data, right? And I want to honor what you said, because I think it's a great idea, but for this district need and the timeline aspect of it, do we feel like 2 months is enough time to at least solidify among these issues, which one we're going with and the blurb?
I mean, for what it's worth, I think it like, I'm perfectly, as the person who put forward capacity, I'm perfectly happy in the next, for our next meeting, writing a blurb that is substantiated with data based on our
Mhm.
actual district need, what we could put forward, and I think also potentially any capital improvements that we're requesting. So I'm happy to do that, and at least that we would have one data
Mhm.
point that we could have to work with, and I don't know, I mean, I don't wanna volunteer you for it, but it sounds like
no,
you've
I've
already
already-
prepared a
Yeah, I've
format.
already
So it
found.
probably like polish it and
Yeah.
you'd have your blurb ready to go within the next 3 weeks, and then LB, not to put you on the spot, but maybe you could pull together what you're thinking from DOH and
Or working
and
partnership.
fashion it enough so we'd have something to work with, and like that could at least be our starting point, and then we
Yeah.
can plan how we wanna do this more robustly next year.
Yeah.
Is that fair?
Exactly,
Yeah.
and then
Yeah.
we will get the superintendent, we'll work on it, and then for next year, we'll start this process even earlier with the surveys
Right
and getting a
away.
lot more information from
Yeah.
the community and parents and teachers and, you know, the parties that are involved more so than some of us here. And for next year, we can have a much better and, like you said, more robust response.
Just a caveat on surveys. You know, there's expertise and how you actually, there's a ton of bias that
Oh,
can
yeah.
be put in, so I don't know that any of us are experts and, I mean, I certainly had, that was part of my education, but I realize how easy it is to kind of dictate what someone's gonna answer us, so
Yeah,
surveys are very
Oh,
complicated.
absolutely,
And they're
yeah.
hard to disseminate too,
Yeah.
because you want diversity and
And
it's
the-
hard to get it out
Yeah.
to everybody.
I was
Yeah.
thinking of more like community conversations. So, you know, collecting the information qualitatively instead of
So
like
not
sort of
quantitative.
like kind of bringing, you know,
yeah.
doing outreach to us, to maybe like a parent teacher organization and asking, you know, we have to like explaining to them what we have to do and that we really like your input and just facilitating a conversation and recording it so that we have the data. And I think that would be a very interesting experience for people too, to be able to discuss these things
Yeah.
among themselves.
Are there
Yeah.
schools of education that are, where there are professors or researchers who are studying the district?
I'm sure we could find out.
I would say there's one big data point that we have is the city wants to kick a whole school out of our district because there's no space for them. And that's just like a as clear as day data point that we do have. All of those are gonna have data that we need. And all our politicians are taking up issue of SALT and trying to, keep powers and trying to find a space for them at what they call
Spark.
Spark, thank you.
Yeah.
And I just think that's like as clear a data point as we have, that trying to kick a whole school out of our district.
No. The
Yeah.
district too.
Out of
School dis-
CD6,
Right.
Community District 6, CD6. Right, they're trying to kick Salk out of CD6. Not District
Yeah.
2, CD6.
Yeah,
Yeah, so I think that's a really important data set, and you saw the parents want to come. Personally, I felt it. Like, people nonstop worried, could they get their kids into school? So I don't know, I think that's just like a really obvious data point right in front of us.
Yeah, that's also an interesting point because, the SALT parents' point is that they say the district superintendent was just put everything on a spreadsheet and figured this is how you manipulate, this is how you make everything fit. And the SALT parents are saying, no, this is a community. There's much more of an organic dynamic in the school. And I think that one concern is that that schools be recognized as individual bodies, and not being, manipulated, just to fit them into the space.
That would be a
That's-
capacity issue. Yeah. I have to tend to agree on that topic. I mean, if you look at what is most urgent in this moment, especially with the smaller class sizes, lack of, not enough teachers. So you have no space, no capacity, educational capacity, or limited educational capacity. All those other things are not gonna matter if there's no schools and no teachers. I'm just I think what you're saying just makes sense, and you're right, for our district, because this is what we're facing. CD6.
So are we talking about school district 2 or
No,
community district 6?
Community
Talk about
district
this.
6.
School District 2 goes all the way up to the upper. east side.
Yeah.
Exactly. All the way down
All
to
the
like.
way to the west side.
Yeah, west side.
Yeah,
Not on
And all the way downtown.
So just here, what we represent, who we represent, our community. We didn't, we don't have any right to be representing anyone else.
No,
This
but
is our
that's how-
mandate.
That's how
Yeah.
the school system is administrated.
No, I know, I mean, I hear what you're saying. Which is very interesting, actually, and a little scary, to be honest.
Oh, that's how.
Because they look at the spreadsheet and they're just like, okay, we'll throw you over there and we'll throw you over there. And kids are
But
so
also,
vulnerable
like,
at that
if
age.
So I went on the New York City Public Schools has a website where if you're a parent looking for a school for your child, you enter your address and say, what grade level you're looking for, and they give you like all the options that you have. And for, like, I put my, CD6 address in there, and there were tons of options for middle schools that were nearby, middle schools or grade 6 through 12 schools. So where the real capacity issue, I think, was for like PS 40.
Right.
Because that's an elementary school in a building that was at 123% capacity. And they had the huge classes for the young kids, which is just not gonna be.
Right, but I think other schools in our community district are similarly facing that capacity issue. It's not just
Mm-hmm.
PS40.
Yeah, I mean, the wealthy
Yeah.
kids are going to Friends, Eunice, and other private schools, so I think. That we're a wealthy district kind of hides that the middle class kids in our district are not. And a lot of people are housing insecure in our neighborhood, and the wealthy kids. That may show up in that are just not really in our public school system.
I think that's true for, that isn't, we have to focus in two different places. I mean, one is the community at large, and the other is the minority in the community that's most disadvantaged. That would be overlooked when we look at the district demographic as a whole. And
Right, 'cause
that's
you're not
true
gonna
in
get that.
education or crime or
No,
health.
That's true in every area.
Yeah.
Right,
Yeah,
right, but that's the
So we
risk,
have to
is that
remember
if
that.
you
Yeah.
forget that the average doesn't you
Yeah,
have to. look at the
there's those below average as well.
So I think one thing we need to think about too is that, are we just thinking about the children and families that live in Community District 6, or are we also thinking about the students who live in other community districts and go to school in a school in Community District 6?
I think we're thinking about students who are educated in community
Yeah.
districts.
Yeah,
I don't think we can
Yeah.
look at Brooklyn and Staten Island and Queens.
no, but what
and
about,
Bronx.
But if you're coming from
'Cause-
70th Street to go to Salk, I think you are counted.
I mean,
Yeah.
because Queens is gonna be closer than the Upper West Side to this area, right? It's right across 59th Street
right,
Bridge.
but there
So
are
I don't think-
children who live in Queens who come into this district to go to public school.
Oh, for sure, but I think we're CD6. This is a problem in CD6, and I think, I feel obligated to help our district and that we represent. And I'm sure people in the West Village,
We're saying the same thing.
yeah,
Yeah.
I think so.
yeah,
Just
but I don't
want
think,
to clarify who we're represented.
I'm sure people in the West Village are not worried, oh, what are the Midtown East people thinking, you know? I'm sure they're just worried about the West Village, you know what I mean? No,
Yeah, but.
and they're good people in the West Village, I love them.
Residents for students and residents.
I think
Yeah,
it's,
we're-
I think if you can join a community board because you work in that neighborhood and you're educated in that
Yeah.
neighborhood, but you don't live in that neighborhood, then we should be considering those people.
I
for
agree.
voting.
I agree with that.
All right, so let's do what, you
Draft
suggested,
plan.
yeah,
Okay,
let's,
great.
so you draft your blurbs, you'll do one, and then Ellie will do one, and the next month
We'll
we'll,
at least have something to work with.
yeah. And then at that point, we can have a discussion and then go from there. And then for next year, we can plan ahead of time, talk to the superintendent, talk to parent-teacher associations and other,
And needs might
Yeah.
shift even, you don't know.
yeah.
This is a moving target.
Yeah. So, yeah, so let's see what we have for next year, but we can do a more in-depth. Study, or not an in-depth study, but we can have a more in-depth look at it.
So we can vote in like September, I think is what you're saying.
So, yeah, I mean, next month would be May, so we don't meet June and July and August.
Wow.
July and
July
August.
and
Yeah, or maybe
Yeah,
we
so
can have a,
we can
we
have
can
a-
try to
We might
get out
have
a
to wrap
plan
it up.
about
Yeah.
how we want to attack.
Yeah.
Yeah.
So,
Qualitative
yeah.
papers.
And then July and August, we are
Yeah.
out, and then September, it's like, we absolutely do need to make a decision by September, because we meet after the October full board. Because our meeting is always the day after the full board, so we can't wait until October, because then we would have missed it. Yeah.
Yeah, great.
Okay, all right. So,
Blurb ready.
Yeah.
Good job.
and then, chair's report,
I'll
Yeah.
see if I can find any. And I just looked and I don't think they break down into,
We could
Just
probably
like-
figure it
Yeah,
out through
look
like
at
two
that.
different things that
It's-
maybe intersect.
all right, chair's report, we had a great health fair. I'm gonna talk to the exec committee next month about officially changing it, and just wanna confirm the name you wanted was health, education and environment, right? Education and environment, health education, yeah. So that's what's gonna be discussed next week at exec and, old new business.
Why are you looking at me? I'm gonna bring it up now. We had a long meeting. Bring it up next.
All right. All right.
I would like to get someone to come in and talk about cannabis, and I'm gonna tell you why.
Okay,
You know, as a reader of Scientific American. The idea that is being generated in general is that this is the safest thing, there's no problems, you know, people support it, whatever. But for young people, there's a lot of issues, and I actually have a family situation where I've got a nephew who's treating anxiety by smoking pot every day, and he's basically losing his mind. Like he's off the charts, not right. So I think, in what we're saying, they're advertising, they put balloons outside, this is not benign, it's not benign, is all I'm saying. I would like someone to really talk to us about what it all means and at age levels, what it means.
we can get somebody from
I
NYU or
agree.
Bellevue or somebody to come talk to us about that. Like a physician or somebody.
Yeah.
Yeah.
But I think it is something that's important, given the expansion of its availability.
All right, and if there's nothing else, meeting adjourned, anything else? I just wanna make sure I'm not cutting anybody off. Meeting adjourned at 8:28.
Thank you so much, everybody. Goodbye.
See you.